Welcome to EASL Studio, your weekly hepatology broadcast news. So in today's episode, we'll be talking about whether it really matters if we call it acute decompensation or acute on chronic liver failure. So I'm Tom Marjot, I'm a hepatologist in Oxford in the UK, and I'm really here to ask the very simple, the very difficult, and the very controversial questions in order to kind of try and make this complex area relevant and accessible to busy clinicians and academics. And I'm delighted to be joined by Paolo and Jules, who need no introduction really. So Paolo Angeli is a professor of hepatology in Padua and has really shaped the whole journey of ACLF from its conception back in the early 2000s right up until modern day trials and therapeutics. And Paolo, you're calling in from Rio de Janeiro today, is that right?
Yeah.
Yeah,
right.
you're our roaming ACLF ambassador today.
Thank you very much.
It's
a big challenge.
Yeah, well, thanks so much for joining us. And also alongside you, we've got Jules Wendon from King's College Hospital in London, who pretty much invented the field of liver intensive care medicine and has such a vast experience in managing our very sickest hepatology patients. So welcome, Jules.
Thank you. It's great to be here.
And so broadly, when we put the studio together, we thought about discussing the impact of terminology, but I want to try and cover three main areas. The first is, how does an ACLF diagnosis inform care at the bedside? The second is how that terminology helps with prognostication and communication with patients and their families. And then lastly, I want to end, if possible, on a really kind of hopeful note about future directions, including treatments and transplantation. And so with all of that in mind, Paolo, maybe I could look to you to kick things off. Can you maybe just give us a 30-second-ish snapshot of what ACLF actually is and how it's different to acute decompensation?
I will try. Well, all of us are aware that there are different definitions of ACLF across the world. But if we speak about acute decompensation and ACLF, it means that we are using the EASL criteria. Said this, ACLF and acute decompensation are different terms. Acute decompensation is the condition sine qua non to develop ACLF. But not all patients who develop acute decompensation then develop ACLF. More in detail, after the development of acute decompensation, they can follow three different trajectories. They can develop organ failure, so they can develop ACLF. They cannot develop organ failure, but need to be readmitted to the hospital frequently during the following 3 months for complications related to the liver disease. And we call this condition unstable decompensated cirrhosis. And the third trajectory is represented by patients who do not develop organ failure, do not need to be readmitted to the hospital, and we call this condition as stable decompensated cirrhosis. So acute decompensation and ACLF are two different terms.
Thanks, Paolo. That's really helpful and really clear. Jules, let's come to you. Are you writing down the term ACLF on your ward rounds day to day? And are your juniors doing it?
So certainly within the intensive care unit, it gets variably written.
Yeah.
But I would say that by and large, it's written when it's ACLF 3.
Okay.
ACLF 1 and 2 probably aren't referred to in the same way. What people write down is the organs that are dysfunctional and failing and the severity thereof, and use a composite of those organ dysfunctions that develop on top of your acute decompensated state.
So do you think it's more helpful to have ACLF in your discussions with colleagues, or is it more helpful to be saying, look, I've got a patient with ascites, AKI, and a chest infection? Does it matter to you which direction you go?
Absolutely. So for me, it's much easier if someone uses the latter terminology, i.e., I've got a patient who's decompensated with ascites, they've now got an acute kidney injury, and they're developing hypoxia and they've got changes on their chest X-ray. For me, that tells me what I need to do in order to further diagnosticate and intervene to try and mitigate the ongoing organ dysfunctions. Whereas,
Yeah, what do you think? Yeah, go on, Jules.
sorry, the ACLF is more determining groupings. It doesn't tell me what I've got to do about it.
Yeah, okay. Paolo, what do you think?
Well, let me say that it is difficult for me to disagree, even partially, with Julia. But, you know, our Cliff C ACLF score can be used just to make the prognosis in a single patient, not in a population. And I think that the stage of ACLF is quite important for the prognostic evaluation. But of course, after the stage in the communication with colleagues, you will highlight the type of organ failure because the weight of the single organ failure is not the same.
Yeah, I hear you. I think we're going to come back to prognostication. I sometimes think, and maybe this is a question for Jules, I wonder sometimes in my own clinical practice whether the term ACLF is sometimes quite a quick and concise way of communicating severity and prognosis between colleagues and maybe between wards and ICU.
I'm not sure. I think you might, yes, it might do, but I would come back to Paolo's point that not all organ failure groupings are the same. So if someone is profoundly hypoxic and in acute renal failure and hypotensive, that will carry for me a different prognostic and determining plan than someone who's got a different group of organ failures, perhaps high bilirubin and encephalopathy. I think there is also a risk that whatever we've done, there is a sense in this world that ACLF carries a really poor prognosis. And if you come in and say, I've got someone with ACLF, will you admit them to ITU? The answer sometimes might be, really not sure where we're going with this. So again, for me, yes, ACLF is a useful phrase. It tells you you've got a sick patient who's on a sticky wicket. You need to intervene. You need to do things. And in that regard, it's really useful. But I think if you're talking to people about escalating care and trying to decide the optimal place to look after that patient, then actually describing the individual organ failures, dysfunctions, is much more useful.
That's really interesting. There's something you said which I don't think I really knew, is that not all organ failure is equal. Is that what I'm hearing? That there's there's different combinations that carry different prognosis. Is that understood, Paolo? And is that represented in the way in which we classify this disease?
Absolutely. You know, the narrative about the communication between a regular ward and ICU depends on individual care setting, on one real world experience. Because in my experience, three factors are crucial in this communication with intensivists in general. First, the severity of the clinical picture. So I can start my communication, say, my patient has an ACLF, but then I will describe the type of organ failure because, of course, respiratory failure, cardiovascular failure, persistent stage 3 AKI have a higher rationale and weight than coagulation or liver failure to justify and to require the transfer of a patient from regular ward to ICU. The second factor is the age of the patient. And the third factor is her or his potential transplant eligibility.
Yeah.
This is my experience, you know.
So
But,
Paolo,
you know,
I think that's
start with ACLF gave immediately the sense of the severity of the clinical picture of the patient.
So maybe, Paolo, what I'm hearing is that just by using the ACLF terminology doesn't mean you then forfeit your ability to describe further. So you can say you've got ACLF, but then you're also allowed to describe the organs that are involved. You're also allowed to describe the precipitant. You're also allowed to describe, you know, the transplant eligibility. So just by using term ACLF doesn't mean you then can't use these very helpful descriptive terms.
Yeah, you're right.
Yeah, that's really helpful. I don't know, looking in as a non-expert on ACLF into this arena, I can't help but think that the field hasn't helped itself with lots of overlapping criteria and definitions. And I wonder if it's confusing for enthusiasts. It's going to be confusing for busy clinicians on the shop floor. What do you think, Paolo? Do you think we need to unify definitions, and has the water been muddied over the years?
Yeah, Tom, I have a privileged observation point of this point because I coordinate the clinical network for liver disease in my region, which connect all the local health facilities with all the hospital. And in our discussion, every day, every week, we use the terms acute decompensation, ACLF. So I think it is very useful, not only in the communication with intensivists, but also with the communication with primary physician, general pathologist, just to put immediately the severity of the clinical picture we are discussing on.
No, I agree. And then I wonder whether we move the conversation on to prognosticating. I think this is maybe provocative. I think academics quite like prognostic scores. But I wonder whether we could come to you, Jules. Are you using prognostic scores? Are you quoting prognostic scores to your patients and their families?
Most of my patients don't talk to me. But
Yeah,
however,
yeah.
sorry, that was
wishful thinking. Yeah.
Response. So do I use prognostic scores? Yes, I do, but not to determine an individual's outcome at their initial admission. So I am very much of the view, and there's been work done in ITU, that it isn't your admitting score that necessarily determines your prognosis, but your response to therapy and treatment. So I would aim to look at what someone's response was at, say, 48, 72 hours, and then begin to determine, because if someone's come in with an acute chest infection, some AKI, perhaps a bacteremia, they've only got a bilirubin that's relatively low, they might sail through this and really improve. By contrast, if you've got someone who's deeply jaundiced, somewhat sarcopenic, and they come in deeply encephalopathic with bacterial peritonitis, and then they get a variceal bleed, and then their kidneys fail 5 days in, you're looking at a very different prognosis. So do I use them? Yes, but does it determine what I'm doing day to day? Not in that immediacy. However, they are useful when you are talking to families in terms of beginning to set a scene and a picture, and they facilitate some of those discussions where you think the prognosis might not be so good. And I think, coming back to a question you raised before, in Europe, we use the EASL definitions, the really useful, we're all aware of them. But then when we do talk to colleagues elsewhere, there's a North American criteria, there are the Asian criteria, all of which are subtly different. And I do think it's important, it's perhaps not for me to comment on, that standardization might be useful at some point.
Yeah, really helpful. Paolo, do you have any comments on prognostic scores?
Yeah, let me go back to the problem of bacterial infection, because our definition of acute decompensation is not perfect. And one of the most important controversial points is to include among the definition acute development of severe bacterial infection. But bacterial infection has never been considered traditionally a decompensating event. It is a precipitant of decompensation. So a patient with compensated cirrhosis and sepsis who develop AKI is quite different, as Julia said before, from a patient who, as a consequence of bacterial infection, develop jaundice, hepatic encephalopathy, ascites, and also bleeding. The term ACLF is appropriate for the second patient. The first one, we can define sepsis-related AKI, for example.
And yeah, we've slightly moved from prognostication to precipitants, but I think it's important. Paolo, just articulate where alcoholic hepatitis, or alcohol-related hepatitis, I should say, fits within the precipitant of either acute decompensation or ACLF.
We know that 50% of the precipitants are represented by bacterial infection or alcohol abuse. So acute alcoholic hepatitis may be a precipitant of ACLF. If we look to the liver biopsy, most of the cases probably that are diagnosed as acute alcohol-related hepatitis are really alcohol-related acute on chronic liver failure. And this is quite important for the management.
Can you say that last bit again, Paolo?
Yeah. If we look to the liver biopsy in patients at home, the final diagnosis was on the clinical ground, acute alcoholic hepatitis. Most of them have underlying cirrhosis.
Mm-hmm.
So the correct diagnosis is not acute alcoholic hepatitis, but alcohol-related acute on chronic liver failure.
I see. That's interesting. So we're almost folding out traditional ALK-HEP into our new diagnosis of ACLF, essentially. Do you have a take on ALK-HEP, Jules?
I suppose.
Do you see it as distinct? Do you see it as distinct, I suppose?
I think I do see it as distinct, but I absolutely hear what Paolo says, that a significant proportion of those patients are cirrhotic. And perhaps some of their liver volume will depend on what their ultimate prognosis is. But that classic picture of alcoholic hepatitis with a high fever, a high white cell count, deeply jaundiced, a big painful liver, that's a cohort that when they develop multiple organ failure, the ITU literature would suggest that they do worse than other cohorts. So it's a little bit, perhaps, as Paolo said, acute infection, bacterial infection when we've grown something is a worse cohort. And perhaps acute alcoholic hepatitis presenting as an acute on chronic liver failure or a critically ill cirrhotic, however you want to define it, they seem to have a worse prognosis than those that are not within that cohort. And I think that's where we need to move forward in refining how we see those organ failures, the precipitants of the organ failures, as we move into trying to use large cohorts to prognosticate for a single patient, which always makes me feel a little uncomfortable. It guides but shouldn't define.
That's a really nice summary, Jules. Thank you. I wonder if I could just move on to kind of our third section, just to leave enough time to talk about the future and where we're heading in terms of treatment. Paolo, maybe I could come to you. Can you maybe just kind of convince me or reassure me that this classification and reclassification and categorization actually ultimately helps us understand disease biology so that we can identify avenues to modify outcomes?
Well, I think that an historical achievement of the description of ACLF in 2013 was to highlight the role of systemic inflammation and oxidative stress as drivers of the syndrome. Because up to that time, we only think that the only driver of decompensation, further decompensation, was a progressive increase in portal hypertension. This is not true for ACLF, you know? And this is quite important because I can give how this change, also the scenario of available treatments. We have not specific treatment to counteract systemic inflammation up to now in patients with ACLF. But we have the possibility to prevent the development of ACLF in patients with acute decompensation, giving albumin. We have now the result of the Preciosa study. Albumin is capable to exert anti-inflammatory action, antioxidative action, And it has been shown that given 1.5 gram of albumin every 10 days for 1 year will increase the 3-month survival in patients with acute decompensation, will reduce the rate of SBP, AKI, hepatic encephalopathy. We are speaking about prevention of ACLF. And this is based on the background we have described with this syndrome.
I think I'm going to pick up on a few points you've raised that I think are really crucial for our listeners. The first is that the terminology ACLF has repositioned systemic inflammation as a key driver here, which is distinct, I think you're saying, from the portal hypertensive drivers that account for acute decompensation. Have I interpreted that correctly, Paolo?
No, let me say that systemic inflammation is a very early process in the course of the liver disease. It is already there in patients with grade 1 ascites. Is the degree of inflammation that is progressively increasing, moving from patient with grade 1 ascites to patient with difficult to treat ascites to patient with acute decompensation, and finally to patient with ACLF. And when the degree of inflammation is very high, it can induce by itself organ failure without the need of any precipitant. In 50% of the case, there is no precipitant of ACLF.
And I think
we cannot identify any precipitant, you know?
And this concept of inflammation, Jules, I think we've previously talked offline about you being able to desperately try and phenotype the patients in front of you into those that are really pro-inflammatory or with immunoparesis, or maybe you could just talk about how you're intuitively trying to phenotype your patients.
So I think the answer to that is badly at the moment.
Yeah, okay.
This to me is the future of where perhaps really sick cirrhotics, the severe acute on chronic liver failure cohort, and the patients in ITU need to go. Timing is everything. And if we want to start intervening, we have got to get our timing right. And it's almost like you are hyperinflamed here and you are immunoparesed here, and you oscillate between these two phenomena with oxidative stress, poor killing of bacteria. All of this is part of the milieu of being a sick patient. I would argue that as clinicians and scientists, we are pretty rubbish at the moment at looking at that at the bedside. We've got a white cell count. We look at lymphocyte neutrophil ratios rarely. We might look at eosinophils if you're particularly into them. I am. Do we look at other markers of immune function? By and large, not. You know, we look at a CRP, which your liver produces. We look at procalcitonin. We know it goes up in inflammation. It doesn't really help us. We've got to get something that allows us to determine whether we want to switch off inflammation or whether we want to stimulate immune function for bacterial killing, fungal killing, viral extinction.
Yeah, this is quite exciting. It's quite, this is biomarker discovery, basically, isn't it? I think it's biomarker discovery to allow you to comprehensively understand what kind of phenotype your ACLF patient is in order to turn inflammation off. But maybe, Paolo, what you're saying, which I hadn't really thought about, is that once they've got to Jules, it might be too late or very difficult to turn inflammation off. And what you're suggesting is actually the best bang for buck is to try and turn off inflammation at the point of decompensation to prevent the evolution of ACLF.
Absolutely. When you don't have an effective treatment, the rule of prevention is crucial. Let me say we have a lot of markers, potential markers of immune dysfunction, of inflammation, but we miss the last step, that is to translate this potential marker into potential target for new treatments, you know? This is the step we have missed up to now. But we have potential marker to define the intensity of inflammation, the severity of immune dysfunction.
Yeah, quite a difficult population to do trials on, Paolo. Is it difficult to recruit into these trials? Are they a very heterogeneous population that makes it difficult to tease out a signal from trials?
We have some trial ongoing, you know. We have the Tango trial testing the combination of an inhibitor of 2-like receptor 4 and GSF factor versus standard of care. But we should wait for the results. We have not the result up to now. But
and probably, go on, Paolo. Sorry, I cut you off.
The field is moving on.
The field is moving, but probably what has been a glimmer, well, more than a glimmer of hope, is the arena of transplantation in this population, which I wanted to just dedicate some time to. Jules, maybe I could come to you. How many patients are you managing to thread the eye of the needle to get to transplantation, and how do they do?
Well, I think a much smaller number than our European colleagues do. I think that's the first thing to say, but I think the UK is now on this track. And I think colleagues, including Will Burnell and colleagues, have done some really nice work in the UK, excuse me, looking at transplanting a very tightly defined group of ACLF3s with a very tight age limit on it and timeline in ICU. And they are having really good results. Exceptional results. And I think the skill in all of this is going to be defining who is at the right point for transplantation, who could get better and be transplanted from a ward environment, who is going to deteriorate come what may and shouldn't be transplanted. And that's, I think we've still got to get our heads around.
What's your continental European experience, Paolo? How are things in Italy from a transplant perspective for ACLF?
Yeah, Tom. In Italy, we have a specific policy to give priority in the waiting list to patients with ACLF. Because let me say that the diagnosis of ACLF has highlighted the disparities that these patients suffer while on the waiting list for liver transplant, when MEL sodium or MEL 3.0 are used for priority allocation. Said this, you know, there is another big trial ongoing, that is the CHANCE trial, that has shown up to now that there is still a great heterogeneity in the access to liver transplant in patients with ACLF across the world.
What was that, Paolo? There's barriers, did you say?
Yeah, heterogeneity across the world.
Heterogeneity, I see what you mean. Yeah, sorry, yeah.
Okay.
Yeah.
And the debate on the futility of liver transplant in patients with ACLF grade 3 is still open. Of course, focusing only on organ failure, we know that the respiratory failure, cardiovascular failure, the need of vasopressor, the need of RRT make the final diagnosis quite difficult. But let me say that the number of organ failure and the type of organ failure is only part of the evaluation of the eligibility of the patient, because many other factors should be included in the debate: sarcopenia, performance status, social and familial support, and so and so and so. It is quite difficult, but the results are quite good. You know, if you select very well the patient, the results are quite good.
And it's been I suppose it is satisfying as a field that there is an avenue to transplantation for a group that was probably previously overlooked for transplantation. Is that fair?
Yeah.
So I think it is very successful. I've listened very carefully. I'm gonna give you my take on what I've heard from you both, and you can tell me if you agree with it. I think, and this will fold in some of my own perspective as a clinical hepatologist on the wards, I think sometimes clinicians get anxious about classification and definitions, because I sometimes think that when you move from decompensated cirrhosis to ACLF, 6 phenotypes of ACLF, different biomarkers, different outcomes, different mechanisms, clinicians start to think that they're walking further and further away from the patient in front of them with ascites and a chest infection. But what I'm also hearing is that embracing that heterogeneity and understanding the different drivers of disease is crucial in order for you to develop treatments. And then you can start to walk closer back towards the patient. And I think transplantation is probably a really good example of that, because the field has spent some time figuring out exactly what subtypes of ACLF are going to do well and where it's beneficial to transplant. And only by doing that have you allowed to then walk back towards the patient to offer them a transplantation. So this is kind of tension, but I think it's necessary perhaps in order to ultimately arrive at better patient outcomes. Do you like that?
Yeah,
Yeah.
I like it.
Do you agree? Yeah,
Absolutely.
I do feel that, you know, there's this kind of to and fro between the tension in clinical practice and actually academic progress, but they very much come together. Are there any other final thoughts from either of you before we start to wrap up? Jules, did you have any take-home messages for us? Is there anything you wanted to emphasize or we've not brought out?
So I think my take-home message is optimism.
Yeah,
Yeah.
okay.
We really need to think of this patient cohort as a group who can be rescued, but with honesty sometimes, that, as we've been talking about, once they've developed significant organ failure and support on ITU, their prognosis becomes much more limited, and we must be realistic and honest with families.
Thanks, Jules. Paolo, any closing thoughts from yourself?
Yeah. Waiting for shared definition of ACLF across the world. This is my hope. My take-home message is to use fully and appropriately the current definition and the current therapeutical option to improve the outcome of your patients.
Thanks so much, Paolo. Jules, that's been such a fantastic and enriching discussion. I'm very grateful for your time. So from the studio team, I think we've got a short break in studio, but we'll be back shortly to explore the new era of effective treatments for PSC. So please do join us for that. And also remember to come and join the EASL family and sign up for membership. It'd be great to have you on board. So Jules, Paolo, thanks once again, and have a lovely rest of your day.
Thank you. Thank you.
Thank you.